All right, so today I welcome you to this session. We shall quickly look at the skin manifestation of HIV. Being in an endemic area of HIV where we stay here in our country, Uganda, it is very paramount for us to know how does the HIV present on the skin, because sometimes the patient presentation can be a skin lesion, then it gives you an insight that actually you may need to screen them for HIV. So as you can see, the pictures that are here, the pictures that I've shown, uh, in this case, we are seeing a patient having a lesion in the oral mucosa, which is the dermatitis, swollen, nodular, plaque-like, and then another one is having all these giant nodules on the face. So another one has this plaques on the skin, and another one has this exophytic mass that is yellow with a yellowish background and all this red and pinkish appearance. So when you see such lesions on the skin, you have to be prompted to do particular investigations to make sure that this patient you're dealing with has no underlying skin condition. So uh, as we can see in this picture, so proceeding to see what HIV infection actually means. So HIV is one of the commonest conditions now we are dealing with in the country. And every time we encourage people to go and check, screen, test, and this can always be triggered by their skin appearance or skin manifestation. So HIV belongs to a family of viruses we call retroviruses. We call them retroviruses because they are able to actually reverse the DNA synthesis once they enter the host cells. So in this case, they make their DNA or genetic material in a reverse pattern. This is what we simply mean. So these viruses exist as RNA viruses, and you know that RNA cannot be made from DNA, right? So what these chaps do is that they reverse their RNA to form DNA, which is now incorporated into the host genome. Then after that, they can now make their RNA from what is incorporated in the host genome. So that process, because of that reverse process, that's why they get their name, the retroviruses. So there are different types, but the ones of interest to them are the ones that belong to the subfamily, the lentiviruses, the lentivirinae. So in this case, we have them being slow-acting viruses, often causing chronic disease. And that's why you have your immune deficiency virus, the HIV type 1 and 2, and then the simian immunodeficiency virus, which usually affects apes. So the associated disease in this case is HIV, stroke AIDS, so the immune deficiency syndrome. And this is how they look like. In their central core, they'll have this RNA genome surrounded by a protein capsid, which is usually derived from the host cell. Then they'll have this special enzyme, the one we call reverse transcriptase enzyme, and then also integrase enzymes that help it to incorporate into the host DNA to cause replication. So the other group that we have the summa viruses, and these ones don't cause infection in humans. We have the human viruses and then the simian viruses. So when you look at the structure of these viruses, these are surrounded by a lipid layer derived from the host cell. Then they have the surface glycoprotein, the glycoprotein G120 and the glycoprotein 41. And this will also allow them to bind to the host cells, as you're going to see as subsequently. They have a protein shell that is encoded by the special protein or gene, the P24, and they also have a single-stranded RNA, a single-stranded RNA genome. They have special enzymes, the reverse transcriptase that I talked about, integrase, and then proteases that help in infection. So in this cycle or in this diagram, we try to look at how these viruses affect the body. And upon infection, if this is your virus coming in, it will use special proteins to bind to the cell of the target host cell. So the special protein they usually use is the glycoprotein, the one we've seen, glycoprotein 120, and then also the glycoprotein 41. So these ones will bind to the CD4 receptors on the cell, like this is the CD4 receptor, plus the accessory receptors that help the binding, that is the CCR5 and the CXR4 receptors. So after they have bound to this receptor, then the genome will be released into the cell, and when that happens, it will undergo reverse transcription to convert it back into DNA. Now this DNA will now be imported into the nucleus of that cell, where it will be integrated into the genome of that cell using an enzyme, integrase enzyme. So after that, now they can trigger transcription, which will end up forming for you different messenger RNAs that are later translated to form the viral copies. So after that, the viral copies will be now assembled in the cytoplasm, and they will bud out, being encapsulated by part of the cell membrane of the host, and the cycle will continue. So this is how the virus affects your cells. So what you have to remember here are the special steps, especially the fusion, where the virus now fuses with the cell membrane using these special proteins, glycoprotein 120 and 41, binding to the CD4 and the CCR5 and CXCR4 receptors. Then the integration, the reverse, then the transcription and assembly, then the maturation, or what we call binding. So this is just repeat the same picture, but now in this case we are now focusing and adding the different drugs that where the different drugs act. So depending on the step of the infection, we can target the drugs depending on the different levels. We can have drugs that prevent the virus from attaching to the cells. Those are called fusion inhibitors. We can also have drugs that block the co-receptors, the CCR5 inhibitors, so that the virus can not bind those receptors. Then we can have drugs that can target the reverse transcriptase enzyme. Those are the nucleotide and then nucleoside reverse transcriptase inhibitors. And then you can have drugs that can prevent the integration of the virus into the host DNA. Those are the integrase inhibitors. Then you can have drugs that can prevent the host cell from making the proteins of the virus. These are the protease inhibitors. So the different antiretrovirus medicine that we have target these key processes in the viral replication. Okay, so if we are to continue, now we have key processes that we need to understand when we are talking about HIV. So the key features that we look at here is that HIV itself can induce a very wide range of skin infections, which can either be because of the infections that come with it, opportunistic infection, inflammatory condition, or even malignant conditions that occur because of the immune dysregulation that comes with HIV. Then you have to correlate now the immune status of the patient with the skin manifestations that we see. So some skin conditions are seen at different levels of immune status, or the CD4 levels. So we have to know the CD4 of the patient, and then we can now start to look for the suspected manifestations that can occur at that different level of immune suppression. Then these conditions can have a severe manifestations as compared to people who are immune competent, and they can have unusual presentations. Like, for example, you can have giant molluscum contagiosum that presents in HIV, which cannot be seen in another person who has no HIV. We can have extensive seborrheic dermatitis that is not easily treated. We can have refractory herpes simplex viral infection that may also indicate HIV infection. And then some people can also react when you start the medicine. So we can have reactivation of the latent infections like tuberculosis. We can have awakening of sleeping opportunistic infections. So someone can end up with immune reconstitution syndrome because you have started medicine, then they'll have skin manifestation. Then the important thing that you have to note is that because of now the art treatment that is now increasing in coverage, some of these conditions are turning out to be now less and less commonly seen, but they can still occur in patients who are reluctant to take this medication. Then you can also have drug reactions that can stem from the medication we use in treatment of HIV. For example, we give septrin, which can also trigger cutaneous reactions like eczematic drug eruptions. So when we look at the epidemiology of how common is HIV, according to the current statistics, WHO estimates to have about 39.9 million people living with HIV globally, but most of these cases are seen in the sub-Saharan Africa. Up to 70% of these cases are in sub-Saharan Africa. And currently in our country, Uganda, we have about 1.4 million people living with HIV. So art has improved in coverage, the antiretroviral therapy, and this one has helped us to reduce the deaths associated with HIV. And the transmission trends have now changed. Initially, it was sexual and vertical transmission, but now we also have a new trend of men having sex with men that has also led to an increase in HIV transmission. And this is usually common in people with high incomes, that where these practices are more common and more commonly done. So this diagram here tries to illustrate the different stages of HIV as given by the WHO and how the skin will look like. So we classify HIV into 4 stages. Clinically, the first stage being the asymptomatic stage that usually correlates with someone having a CD4 count of about 500. And in this case, someone has no manifestation, the skin is okay. Sometimes they just have persistent lymphadenopathy, but basically the skin looks normal. Then in the second stage, which is mild or and it could correlate with immune status, where the CD4 counts about 350 to 499 cells per millimeter cubed. So in this case, you can start to see skin manifestations, including herpes zoster, superficial fungal nail infections, PPEs, pruritic papular eruptions, angular cheilitis, recurrent oral ulcerations, and abscess ulcer, but sometimes you see even extensive seborrheic dermatitis, unexplained weight loss of less than 10% of the body weight. Then you can have extensive warts, especially in children, extensive molluscum contagiosum, then gingival erythema, then unexplained persistent hepatosplenomegaly. So when you go to the stage 3, so in this case, someone has an advanced type of HIV. So this correlates if your CD4 count goes between 200 to 359. So in this case, you can get persistent or candidiasis or leukoplakia secondary to Epstein virus infection. Then you can get acute necrotizing ulcerative stomatitis or gingivitis or periodontitis and unexplained chronic diarrhea. Now, in this case, you start to get a diarrhea, and then also weight loss increases to be a little bit more than 10% of your body weight. And then sometimes you have now moderate mild to moderate malnutrition. So when you see such presentation in a patient, then the class or the clinical stage will change. Then in stage 4, where we say severe AIDS, or in this case, you have the AIDS defining condition where your CD4 goes below 200. And in this case, you'll have people having chronic herpes simplex infections. You'll have patients presenting with extra pulmonary, or that is skin cryptococcosis, and other severe forms of all the opportunistic infection, including the non-tuberculous mycobacter infections, including severe forms of cytomegalovirus infection, including HIV, encephalopathy, delirium, pneumocystis, pneumonia, and the rest. So in this case, these are very, very ill patients that are admitted with sometimes very, very poor outcome. So in this case, this table tries to correlate, now they tries to correlate the dermatological manifestations with the CD4 count of the patient. So if the patient has CD4 count is above to 500, sometimes on the skin you may only see maybe oral leukoplakia, vaginal candidiasis, and then septum. The rest you may not see. But if it goes below, then it starts the pharyngeal candidiasis, the zoster, the psoriasis becoming severe, and then atypical melanocytic nevi and the rest. So if the CD4 count goes below 250, then you get eosinophilic folliculitis, severe refractory seborrheic dermatitis, cryptococcosis, which can be disseminated, isoplasmosis, osteoendomycosis, and the rest, and also some cancers like non-Hodgkin's lymphoma. So if the CD4 is above 50, in this case it is severe, and you have all what is mentioned before plus all these other diseases, even the typical microbacterial infection, the major ulcers, and the rest. So in this case, you will also have different manifestations in the rest of the systems, like respiratory, nervous, hematological, and myelopathy. So these ones are covered in other sections. So now this one becomes key. This one becomes key if you are to look at the HIV and how it progresses in the body. So we have what we call the window period, or in that period whereby you're not able actually to detect the virus in a person who is actually infected. So in this case, we can look at this diagram and then we see how the different antigens can be detected and how the disease progresses. So the first blue line, you see that the uh, the virus, if we get infected here at this area here, the viral genome, it will start replicating, it will increase, give you a peak viremia, then your body will wake up, be aware, then it will go into some form of latent period. Then this one after about 25 years, then the virus will multiply again after destroying most of your CD4 cells. So in terms of detection, the different detection methods, for example, if you are to detect the P24 antigen, it will start around this time here, around the 15th day, because that's when the antigen starts to increase in the body. Then it will stop around 50 days. Then if you have to do antibody, that is the third generation amino acid, it will start around day 25. Then if you have to do the antibody detection, it will start around 30 to 40 days. So that's why we have a full month where you cannot use antibody antigen tests, these strips, to detect HIV. But for PCR, it comes a little bit early. So this period here from here up here is what we call the window period. So after that, we have a phase of clinical latency whereby the person is okay, but the virus is continuously dividing, and you find that almost all the tests can now be positive. Then after that, we get overt AIDS if someone has not started medication with opportunistic infections and the rest. So skin-wise or dermatology-wise, this is the clinical manifestation that we shall usually see. We have what we call the primary HIV exanthem, also called the acute retroviral syndrome. So in this case, this is the skin manifestation that we usually see during the window period of HIV when someone is doing seroconversion. So in this case, you'll have a body reacting to the RNA and DNA and the P24 antigens. And in this case, that's when you get the symptoms. So someone will have flu-like symptoms, joint pains, a sore throat, persistent lymphadenopathy, headaches, fevers, and on the skin, up to 80% of the patients may get a generalized mobiliform eruption that typically presents affecting the face and the trunk, and it may last for about 4 to 5 days. After that, it will clear and the person will be occasionally, we can get all involvement where you get all ulcers and then dental ulcers as well have been reported in a few cases, but most of the times, some people can go through this phase actually without any skin manifestation. So this is usually self-limited and it will resolve in about 14 days. And if you are to do testing in this case, there's usually a rapid decrease or a temporary decrease in the CD4 count. And after that, sometimes people can If it is so rapid, some people can even get opportunistic infections in this period, though rarely. And after that, the immune system tries to stabilize, and then we enter the clinical latency phase. And the severe symptoms usually implicate that someone will have a rapid progression of the disease, so HIV, compared to someone who has no um, initial manifestation. So the importance of this phase is that if you identify a patient and start medicine right away in this phase, it is very, very key because you prevent progression of the disease and they can be on medicine without any problem or without any other opportunistic infection affecting them. So what do we have to note in HIV? So in HIV lowers your immune response because it affects your CD4 cells. So that means that all the infections that are supposed to be handled by this by your immune system, they will present in a severe form or in a very bad type. So even in HIV, we get a skin condition like herpes simplex, which is usually self-limited in a normal individual, causing you resistant of long-standing ulcers in someone living with HIV. So to start with, if you are to get a clinical manifestation of herpes simplex virus in HIV, in this case, someone will have more lesions, more recurrences, more than 6 times in a year, and every time they have an episode, it stays longer than in a normal person. So the typical presentations are present. On top of that, someone will also have a typical presentation. So in this case, you can have herpes simplex causing folliculitis, causing verrucous plaques, causing hypertrophic plaques, which is never the case in a normal person. Then they can also cause anogenital masses, which can look like even neoplasms or even cancers. Then what you have to note is that if someone has HSV2, it can also promote the replication of HIV-1, especially in the genitalia. So if someone is co-infected with HIV and HSV, they become more infectious, even when it comes to HIV, because you know that when you have HSV infection, since it is viral, the response is usually T-cell mediated. And you know, in the tissues that you are recruiting, most of them are HIV infected. So as they're replicating, they make the virus HIV also to replicate, making them to be very, very infectious. So we should treat with acyclovir, but in case there's resistance to acyclovir, you can use drugs like foscarnet, cidofovir, or even imiquimod. Then the next condition, we call it varicella zoster. So in varicella zoster, in HIV, you still the patient will have lesions lasting longer and more lesions, and they take long to heal. So they can also present with complications like pneumonitis, hepatitis, and even encephalitis. So these lesions will persist and they'll leave you with slow healing ulcers. And there's even an increased risk of getting varicella zoster, which is like 7 to 15 times higher than the normal individuals. And in this case, it can persist as chronic ulcer. So as you can see in this picture, this is a patient who had chronic ulcerations around the perianal area, secondary to herpes simplex virus. So the next virus, we call it molluscum contagiosum. So this one also affects any individual, but when it comes to HIV, it becomes more stubborn, more severe, and more atypical. So in this case, the patient will present with very giant molluscum, which may be even more than 1 centimeter in diameter. Some of them coalesce to form verrucous plaques and widespread lesions, which are very persistent and are stubborn to treatment. As you can see in this picture, this is a very giant singular molluscum, which can even simulate a basal cell carcinoma. You see this giant molluscum with mollusk bodies and this whitish amplification at the center. But in this case, patient living with HIV becomes severe. So the next condition is what we call a human papillomavirus. So this one also occurs in normal individuals, but when it comes to HIV, it can cause a mess. And in this case, the person can present with the common words that we've seen before. So giant corneum acuminata. Sometimes they progress into squamous intraepithelial neoplasia and even carcinomas. And the prevalence of human papillomavirus is high in patients living with HIV. And sometimes they can also end up with acquired epidermal dysplasia, the response. So as you can see in this picture, this is a person who had HIV with this giant verrucous plaques on the hands, and now this one has a giant condyloma acuminata in the perianal area. These ones are very hard to treat, high recurrence rates, and very stubborn to medicine. So the next one is the Epstein-Barr virus. Usually this one causes oral air leukoplakia in people living with HIV, which presents with hyperkeratotic corrugated white plaques with hair-like projections on the lateral aspects of the tongue. It can occur at any stage of HIV, and we've seen it even in clinical stage 1, 2, 3, up to 4. And sometimes it's not limited only to HIV, it can occur in other people who are compromised, especially those living with other malignancies on chemotherapy and immune suppressive drugs like tumor necrosis factor alpha inhibitors. They can present with this oral air leukoplakia secondary to Epstein-Barr virus. So treatment usually give antiretroviral medicine, including the acyclovir, but you can add topical photophylotoxin, tretinoin, and then gentine violet to try and remove these verrucous plaques on the tongue. Then the next condition or disease can be due to cytomegalovirus. So in this case, it is usually reactivated every time the patient's CD4 count falls below 100. So they can present with rhinitis, esophagitis, colitis as the common manifestation. And in this case, on the skin, they can have magenta ulcers, as we've seen in HSV and varicella. They can get verrucous plaques, pruritic nodules-like lesions, and then pruritic papular vesicles, and sometimes they can also develop a generalized measles-like or morbidiform eruption. So as you can see in this patient has lesions that can mimic pruritic nodularis, but in this case, CMV virus was isolated, being the causative agent. So when you go to the viral infections, the bacterial infections can also be a menace in HIV. So being in an immunosuppressive state, even the bacteria are not well thought of. So the first one we shall look at the Staphylococcus aureus, and this bacteria in HIV has been noted to be one of the leading causes of bacterial infections of the skin in people living with HIV. So it will present like impetigo, cellulitis, and sometimes these people have an increased risk of the methicillin-resistant Staphylococcus infections. And commonly, they can have these lesions on the lower extremities, the buttocks, especially the intergluteal area, the sacrum. And every time the CD4 goes down, they get a risk of developing these conditions. So we usually treat them with topical mupirocin, and then they can get a chlorhexidine baths to try and lower the cardiac state, and that can improve their outcome. So we have another condition called bacterial angiomatosis caused by Bottonella species, the Bottonella quintana and Hensi. So in this case, we usually see it in patients where their CD4 count falls below 100, and it presents like pyoderma, like pyogenic granuloma, but in this case can be diffuse, covering the entire body or in the genitalia, very many lesions which will look like fresh erythematous fungating masses, papules or plaques. And in this case, sometimes they can get a similar manifestation in internal organs, which can be easily bleed, resulting into internal bleeds. They can actually lead the patient to death. So we usually treat with the doxycycline or any macrolide like azithromycin or erythromycin, and the patient will be better. They usually have other symptoms like fever, weight loss, and this can also be attributed to HIV as well as other opportunistic infections like TB, which occurs concurrently with HIV. So we also have mycobacterial infection, patients living with HIV, tuberculosis being one of the commonest. And currently the treatment protocol requires you to screen for tuberculosis before starting at treatment. Because if you don't, you can end up reactivating the bacteria, causing a menace or even death of a patient. So positive patients can develop a wide range of for mycobacterial infections, including nodules, ulcers, acneiform eruption, abscesses, verrucous plaques, protrichoid patterns, and the rest. So in this case, for example, this patient who had a sporotrichoid pattern of these other cells was also living with HIV. And when you take off a biopsy, you will see caseous necrosis. And in that case, you also manage the TB as you manage the HIV as well. Then the other condition that we usually see in HIV is syphilis. And in this case of HIV, syphilis presents now more where, syphilis is one of the diseases we call a great mimicker because it can look like all other skin conditions. So it can manifest in varied or in various forms. So in this case, in HIV, it becomes even worse because HIV also comes, syphilis, it comes with more atypical forms. So we are usually used to a single primary chancre in other individuals, but in HIV, someone can have more chancres, like even 7, 5 in different body parts of primary syphilis. And the classical papular eruption is also common, but sometimes someone can have manifestation of primary chancre together with secondary rash at the same time. And the progression from primary to secondary to tertiary syphilis is shortened, and sometimes they overlap. So you have features in the primary syphilis, features for secondary, features for tertiary syphilis at the same time. As you can see in this picture, we will have these copper coin lesions on the palms and toes, which are usually commonly seen in syphilis. So when you go to fungal infections in HIV, usually these ones become a menace because even the normal flora of fungus can end up causing disease conditions in people living with HIV. So Candida is the most common fungus that causes infections in HIV. It can give you oropharyngeal candidiasis. This one is usually seen in the clinical stage 2, 3, and 4. You can end up with angular keratitis because of Candida, chronic paronychia, mucodystrophy, as well as intravenous refractory vaginal, esophageal, or even disseminated candidiasis. So even HIV, candidiasis can end up causing systemic symptoms, even going all the way to causing meningitis. So this is how the nail will look like. Someone has chronic paronychia secondary to candida. Then when it comes to the dermatophytes that cause usually the tinnias, they also enjoy this type because they give you a typical presentation and very refractory to treatment. You treat and the thing is not going away. So someone will have the proximal onychomycosis secondary dermatophyte and have the superficial white onychomycosis. And in this case, they're usually severe forms. As you can see in this picture, someone has this giant erythematous plaque with an active border and with central clearance together with other annular plaques also inside the giant one. So this is still tinea corporis, but in this time around, it's occurring in someone living with HIV. So systemic fungal infections in HIV are usually very severe and disseminated. So that's where you get the disseminated cryptococcosis, you get the dimorphic fungus like histoplasmosis, blastomycosis, coccidioidomycosis, paracoccidioidomycosis, penicillosis, and sporotrichosis. All of them coming to cause infection in HIV. So every time you have a patient with HIV and they have this atypical presentation, you need to be a little bit very, very careful because their presentation is usually atypical and usually severe. So when you are to look at this picture, this is disseminated cryptococcosis, and this is histoplasmosis, which looks like molluscum contagiosum. But in that case, when you take off a biopsy and the sample, it will look like that. So when you go to parasitic infections still in HIV, they are also usually very, very severe. So you have the first one being leishmaniasis, transmitted by the sandflies. So leishmania, when it comes to HIV, it gives a severe form. This is because HIV enhances the severity of leishmania. Because we know that in HIV, there's a shift from T helper 1, which are usually protective, to T helper 2. So this shift allows for leishmania to thrive because you have no protection against leishmania. So we know the diagnosis in this case is usually culture. Then you can also do a PCR, but the clinical picture can also give you an idea, also culture, and biopsy can also give you a picture. Usually, leishmania in HIV is very resistant to treatment. The relapses are very, very common, and then it comes with increased mortality. So in this picture, we see this nodular plaques on the face of the patient with leishmania and also living with HIV. Then when you go to the worms, the strongyloiditis or diasis or these worms. So in this case, someone will have urticaria or even lava curems, and it is usually more severe. And in HIV, there has been a report that different cases reported whereby the strongyloids are causing what we call the thumbprint papilla or papular lesions or petechiae, usually which occur on the trunk and the thumb. That's why it is called the thumbprint papilla, and it's also common in people living with HIV or any immune-compromised individual. So when you see easy bleeding on the trunk of an HIV individual, you may also think about parasitic infections being the underlying cause. So when you go to the ectoparasites and infestations and skin bites, scabies, when it comes to HIV, it will be severe. In this case, if your CD4 is below 200, you present with this extensive crusted scabies, we call Norwegian scabies, and the patient will present with these scaly plaques that have millions and millions of mites that are even very easy to diagnose and very infectious. Then people living with HIV also suffer from demodicosis, which is usually a normal mite in everybody, but in HIV it ends up causing folliculitis, rosacea, and sometimes even blepharitis can come from these mites. Then insect bites, the papular urticaria that we have seen in other individuals when it comes to HIV, the reaction is usually severe, and people end up with pruritic or nodule-like lesions just from simple insect bites. So we proceed now to the non-infectious HIV-related dermatoses. So this one, the first one being seborrheic dermatitis. The seborrheic dermatitis is usually more of an allergic mediated reaction where someone has hypersensitivity to the normal Malassezia species that are supposed to be the normal flora on the skin. But when it comes to HIV, the seborrheic dermatitis becomes severe, recalcitrant, and very resistant to treatment, and it will affect about even up to 40% of people living with HIV. So the next one is psoriasis. Psoriasis is very severe in HIV. This one has been postulated to be due to reduced cells in the body, and then also postulated to be due to immunoconstitution that makes inflammation severe. So when you have HIV and then you start medicine, then you have that immunoconstitution syndrome that makes any inflammatory process to be severe. That's why psoriasis becomes severe in HIV. Then you also have reactive arthritis, which is commonly seen in people with human leukocyte antigen B27. HIV makes it severe and very hard to treat. And xerosis is another common dermatosis that occurs in people living with HIV, presenting primarily with itching and pruritic, itching of skin. Then atopic dermatitis, also more common in HIV children. This is due to still the shift that we talked about, shift from T helper 1 to T helper 2 because of the HIV. As you can see in this picture here, now this is a severe form of psoriasis, where you don't have you have the typical lesions, but even the scale isn't that marked, but it is very extensive, almost reaching the level we call a exodermic, where it covers 90% of the surface area. Then another condition that we see in HIV, we call it pruritic papular eruption, commonly called the PPEs. So in this case, someone presents with severe pruritus of the skin, and in this case, someone has skin-colored or erythematous papules, which are non-follicular. So in this case, the lesions are in between the hair follicles, symmetrically distributed on the trunk and limbs, and it has been postulated to be due to hypersensitivity reaction to arthropod antigens. Then this one has to be distinguished from eosinophilic folliculitis, because this one we have to use it occurs on the trunk and limbs as well. But eosinophilic folliculitis is also intensely pruritic. You have erythematous by the same round follicular-based papules. This one is inhibiting the papules are inhibiting the hair follicles. Then the second one is the papules are follicular. So commonly seen on the scalp, face, neck, and upper trunk. and they say that the reaction usually is above the nipple line. The nipple line. But sometimes we can take the umbilicus, below the umbilicus and above. That's where you find the eosinophilic folliculitis. So it is usually seen in advanced HIV disease, where the CD4 count goes below 250, and we think that it is an exaggerated reaction to myathesia and also the demodex mites, which are usually seen in the seborrheic areas, more concentrated in the seborrheic areas. So this is how the picture will look like. Someone has this erythematous follicular papules on the upper part of the body above the nipple line. So another condition that usually we see in HIV is what we call vasculitis. So vasculitis is just inflammation of blood vessels. So in HIV, we can have a range of vasculitis, starting from small vessel vasculitis, the polyarteritis nodosa, and the mechanism is thought to be deposition of immune complexes in the blood vessels that end up triggering activation of the complement system that fights that cause an inflammation to the blood vessels. But also, HIV can also occur with other infections, including hepatitis B, and hepatitis C, and other opportunistic infections like CMV and cryptococcal infections that can also exacerbate the vasculitis, because even them, in their pathomechanisms, they have um, vasculitis implicated. Then the other condition that we see is what we call photosensitivity reactions. So in HIV, we usually see people now becoming more sensitive to light, to the sunlight, and they can present with UV photosensitivity syndromes. This is usually due to even the drugs that we give, like septrin. They can also present with porphyria actinium tada, and this is usually the acquired type. Can also be related to infection with hepatitis B and hepatitis B, co-infection in HIV as well. They also get chronic actinic dermatitis, especially if the CD4 goes below 200. So it has been demonstrated that when your CD4 level goes below 200, your minimum erythematous dose also drops. So that makes you to be more photosensitive. So that is what exactly occurs in HIV. So in HIV, you have a low CD4 count, which was your minimum erythematous dose, making you photosensitive. Then we have also metabolic changes that have been reported with HIV. So in this case, the common one is the lipodystrophy. In this case, you can have increased or reduced fat in the body. And it has been shown that the lipoatrophy, which is low fat, especially which occurs on the face area, it is associated with the inhibition of the mitochondrial DNA polymerase, causing a breakdown of more fat from the facial area. So someone ends up with the atrophy on the face. And then there's also lipohypertrophy. In this case, this one occurs on the trunk. Now, this has been associated with the altered lymphocyte function, which is caused by HIV, and also chronic inflammation that also comes with HIV that allows for more deposition of fat in the trunk area. So someone loses fat in the face, but puts it back on the, puts more fat on the trunk. So they have that characteristic picture of central facial atrophy. Then we can also end up with malnutrition in HIV, and the malnutrition dermatosis also come in with it. So this is because when living with this condition, someone can develop reduced appetite, so food intake goes down, so they can end up with malnutrition. They can have other conditions that impede eating, like esophageal candidiasis. So since you're not eating, then your nutrition status also deteriorates. Sometimes like in a stage 3 where they have this recurrent diarrhea, persistent diarrhea, all of this and the infection, the malignancies that come with HIV, all this contribute to the malnutrition. Then it can end up with malabsorption and also social issues like poverty and the rest and the psych, because of the depression, the anxiety, and psychiatric disorders that can also manifest with HIV, the psychosis, HIV psychosis, and the rest can also impede eating, and then someone ends up with malnutrition. So they can present with zinc deficiency, dermatosis like sloughing of skin and the rest. They can present with niacin deficiency disorders like pellagra. They can present with micronutrient deficiency disorders like thinning of hairs and the rest. And all these are very, very key when you are managing people with HIV. So we have other miscellaneous dermatologies like primary cutaneous mucinosis, which has been also reported mainly in people living with HIV, has been associated there. Major apathy ulcers, melanoma annuli, and then also linear telangiectasia on the chest. Those ones are usually tiny blood vessels that have been reported in people living with HIV, especially on their chest. So all these dermatoses have been associated with HIV. So we go to now the HIV-associated cancers or neoplasms. So we have Kaposi sarcoma, which is HIV-associated. This is very common, and it is linked to infection with human herpes H. It is very common in individuals who are living with HIV, which brings about the immune suppression. So the characteristic lesion, someone will have red, purple to brown macules, later on plaques, then nodules, later on tumors, which can affect the face, the oral cavity, the extremities, the trunk, and sometimes you can also end up with visceral involvement. So risk factor, if your CD4 falls, and in case you have advanced HIV, and then if you delay to start ACT in HIV, you have a risk of getting this Kaposi sarcoma. So in the diagnosis is usually based on clinical, then you take off a biopsy, and you are able to do a PCR. You can also detect the genome or the DNA for the human herpes virus number 8. So in treatment, we usually give retroviral therapy, the anti-HIV medicine. Then sometimes people improve with that, but may end up needing maybe chemotherapy if it is widespread, and as well as radiotherapy to try and calm down this malignancy. So this is how it will look like. You see the versions in the oral mucosa. This is Kaposi sarcoma, and it can have that picture. You have this gingival hyperplasia. You have this nodular publish plaques on the hard palate. So this is your Kaposi sarcoma. Sometimes it can start on the leg, they will see these nodules and plaques. Sometimes it comes with chronic lymphedema, and then you can end up with elephantiasis, and in that case, you need to manage the patient in due time. So other malignancies that have been implicated in HIV to increase in prevalence, we have squamous cell carcinoma, basal cell carcinoma, lymphomas, melanomas, and sometimes we need also to watch for drug reaction every time you start people on medicine, including breast, which is drug reaction with eosinophilia and systemic symptoms, very common in people living with HIV. Once they are started the medicine, they can also develop AGEP, which is acute generalized epixanthomatous pustulosis. They can develop toxic epidermal necrosis, Stevens-Johnson syndrome, epidermatous drug eruptions, and point to note is that we've made a video for all these drug reactions. You can go and watch it. And we have also made a video for all these malignancies. You can as well go and watch them. So we encourage you to subscribe to this channel such that you get more people to watch this important information. And point to note is that every time you're managing a patient living with HIV, you need to put into consideration the skin manifestations, or if you're managing any patient in dermatology, you have to ask yourself, this skin manifestation can it be due to HIV? Then you have to end up screening the patient for HIV and syphilis as well. So routinely in the dermatology setting, HIV screening and syphilis testing should be a must or mandatory in all patients. Thank you very much. See you in the next video. I'm Abraham from A&E Dermatology Specialist. Have a good one. God bless you.